So we talked a lot about HPV and its implications on prognosis, but there are other factors that we consider. Let's talk a little bit about those. Kevin, what other things come into play when you are discussing prognosis with a patient?
Well, the first thing that we will look at is we will stage the patient's tumors. So we know that patients with high T stage, especially those patients with T3 and T4 tumors, have a worse prognosis. We know that patients with high end stage, and this includes both HPV negative and HPV positive disease, even though there's a tendency for HPV positive disease to present at stage N2 and above fairly commonly, but we know that those higher end stages for both negative and HPV positive disease will have a prognostic benefit. And then we have to consider patient-associated factors, so the patient's age, the patient's general performance status, and comorbid conditions. And these are the sort of factors that we would routinely take into account when designing treatment plans for these patients and deciding whether or not they are fit for unimodality or multimodality therapy, whether or not they are candidates for surgical or non-surgical management.
And Victor, any other factors that you take into account?
No, I think Kevin really summarized all those that are really essential, because something you really would like to avoid is that you challenge a patient with a multimodality approach which he cannot handle, basically. And I think it is very important with these multimodal aggressive treatments to select the right patient to the right treatment. And as Kevin said, these are the factors that we also use, and they're important in the clinic.
A lot of things to consider when facing an individual patient. Tanguy, any other molecular markers that you use to think about prognosis?
So clinically, we do exactly what Kevin and Viktor pointed out, and I think that's a standard of care. I do believe that there are factors that we're investigating that are research essays that might help. There's a lot of talk about the immune system, the immunoscore, and we actually don't know what the impact is, but the suggestion may be that patients who already have a pre-existing immune response might do better. We actually don't know the answer for head and neck cancer, so I think we don't know that. There are other factors that have been described. There are actually heterogeneities regarding P53 status. Does presence or absence of a P53 mutation mean something? Then also the dignity of the P53 mutation specifically. And I think it's a bit controversial. So clinically, we don't use either of those factors. Other things are being explored, but I think it's important for us to keep looking and further refine this. And just to comment on Kevin's point a little bit more, I think for the HPV positive tumors, there's a general sense that even though somebody is quote unquote local region advanced, they actually behave so much more favorably that even though they're local region advanced by prognosis, they actually more mirror the intermediate stage HPV negative tumors. So very good outcomes.
Yes, I think that's true. But again, I think for those patients with T4, N2C, and especially N3 disease, we know that although our local and loco-regional therapies, including chemoradiation, may be particularly successful in controlling disease above the clavicles, that's the group of patients where we have the concern about metastatic relapse, either in the early or including in the later phases of their disease process.
And in fact, Kevin, the new HNSCC staging is going to take that exactly into account for HPV positive disease.